Okay, we've just hit the magic 100 participant mark, so I think without further ado, we should begin. Hello all, very warm welcome to today's webinar on improving children and young people's mental health with parent-led CBT. Terrific to have such a good turnout. So we're hosted by the Mental Health Implementation Network, that's MHIN for short, with funding from the National Institute for Health and Care Research. MHIN has supported 3 different implementation projects, and today we'll be hearing specifically about work that's been done in relation to children and young people's mental health, and we'll be focusing on the implementation of an exemplar intervention, parent-led CBT. My name is Daniel Mitchelson. I'm a clinical psychologist and a senior lecturer at King's College London. I co-led a consortium of researchers, practitioners, and lived experience experts in support of this project. I am co-chairing today along with the project co-lead Becca Randall.
Hi, I'm Becca Randall, and I'm the implementation lead for children's mental health at Kempsey in Sussex ARC and Health Innovation Network, and I've been co-leading this partnership, national partnership with Daniel.
Thanks, Becca. So just a few housekeeping issues to mention before we hand over to the speakers. So we've set this up as a webinar rather than a sort of regular Zoom call. So all attendees are sort of muted throughout the event. And rather than using the standard chat function, we're using the Q&A function, which you'll see in the toolbar at the bottom of your screen. So just because of the very packed agenda, we're not going to be able to do a sort of standard sort of Q&A where people put virtual hands up. But as we go along, if you have a specific question, please put it in the Q&A. And if possible, sort of do an @ sign to indicate who your question is directed towards. And we will try to respond to these questions sort of in real time as we go along. If we don't get to all the questions, we will produce a sort of an FAQ type document that we will circulate to attendees. So also to say the event will be recorded. If you would like to have captions, please enable them on your Zoom screen. If you do encounter any technical issues during the course of the webinar, we've got email addresses here for Lucy Gallagher and Sundus Khalid. Please contact Lucy or Sundus, and we'll try and respond as quickly as we can, and if possible, help give some advice about that. If you would like to tweet about the event, although I don't know what the terminology now is, if you want to send an X message about it, use the relevant handle #MHIN, and then there's some at signs there on the screen. So just onto the agenda now. We do have a very packed agenda with some really superb speakers. So we're going to start by setting the scene with an overview of MHIN's remit. And we're also really fortunate to be able to hear from the developer of parent-led CBT, Professor Kathy Creswell, who's going to be giving a bit of background to the intervention. We are then going to be hearing from 2 teams involved in regional implementation studies. And following on from that, we have a really important slot where parents and caregivers will be providing a lived experience perspective on this work. And to conclude, we have some time set aside for a brief panel discussion involving several of our speakers. And we'll also have an opportunity to think about next steps for those who are currently or will be implementing parent-led CBT in other settings. So let me now just hand over to my colleague, Dr. Khalid, who will be speaking saying a little bit about MHIN's remit. So thanks very much. Over to you, Sundus.
Thank you, Danielle. Hello, everyone. My name is Sundus Khalid, and I'm a postdoctoral researcher for Mental Health Implementation Network, MHIN. And today I'll be giving an overview and history of MHIN. So launched in 2020, MHIN aimed to bridge the gap between research and practice by implementing effective interventions across England. The main objectives were to bring together a diverse group of key stakeholders from different fields, identify and prioritize services that needed improvement, identify evidence-based interventions, decide on practical implementation methods to put those interventions into actions, and then evaluate how well the implementation plan is working, in addition to evaluating MHIN as a priority network as a whole. Next slide, please, Flavia. Thank you. Priority areas were selected through vigorous prioritization process, which included systematic scoping reviews, structured survey, identifying themes and priorities, consulting experts, and conducting decision-making workshops. The 3 finalized areas were improving access to mental health services for minoritized ethnic communities, children, young people's mental health, and integrated care protocol for substance use issues, mental and physical health. Next slide, please, Flavia. Thank you. We then identified evidence-based interventions for prioritized area by reviewing the literature and consulting experts. The identified interventions were then described in details using the intervention description and replication checklists. These details were then used to score the intervention using the AHSN implementability assessments, which had criteria like adoption appetite, cost effectiveness, and patient and public involvement during intervention design and development. So the finalized interventions were patient and care race equality framework, PCREF, parent-led cognitive behavioral therapy, and alcohol assertive outreach teams. If you want a bit more details about the selection process, then please use the QR code to access our prioritization paper, which is published in Frontiers in Health Services. Next slide, please, Flavia. Thank you. The partner ARCs were chosen using an expression of interest process based on local partnerships, implementation plans, and potential impact on addressing inequalities. So in this project, we're collaborating with East of England and Northwest Coast, and you will hear from them regarding their site project soon. Next slide, please, Flavia. So throughout this implementation and evaluation phase, MHIN provided ongoing support and guidance on implementation and evaluation strategies, and we also facilitated public and patient involvement. We're currently analyzing the data for evaluating the MHIN and are excited about the upcoming phase of the network, which you will hear and learn about towards the end of the event, please. Next slide, please. Thank you. And with that, I would like to thank you all for your time and attention, and please, again, use the chat function to ask any questions you may have throughout the event. Thank you.
Great, thanks, Sundus. Now over to Kathy.
Hi, hopefully you can hear and see me okay. My name is Kathy Credder. I'm a Professor of Developmental Clinical Psychology at the University of Oxford, and we were really delighted when the MHIN priority setting exercise planned to focus on implementation of parent-led CBT for child anxiety problems. And I just today I'm just going to give a little bit of background of some of the research that underpinned the work. So I think many of you will know that anxiety problems are extremely common and they have a very early age of onset, and actually much earlier than many other mental health problems that we see. So anxiety problems often first emerge, and actually the peak age for the emergence of anxiety problems in children is within the primary school age range. And we do have treatments that work fairly well. So the treatment that's had the most evaluation is cognitive behavior therapy, psychological therapy that involves helping people test out their thoughts and learn new things that help them overcome anxiety. And we were involved in a large meta-analysis of trials that found that about half of children will be free of their primary anxiety disorder at the end of a course of treatment, which is clearly better than being on a wait list. However, as many of you will know, demand for mental health support for common mental health problems like anxiety problems is extremely high and increasing all the time. And so delivering a course of CBT of the type that's been evaluated in most of those trials is really very difficult to do in a way that meets the need. So typically in those trials, treatments would involve, say, 16 weekly sessions for a child to attend, sometimes the child and the parent. And that's one, very difficult for clinical services to deliver in a way that meets the need, but also obviously can be hugely challenging for families to be able to attend sessions like that when families obviously have so many other commitments as well. I mean, of course, families will generally do everything they can to make it happen, but it's often not easy. So to try to address some of these barriers, some time ago, we developed a form of CBT where essentially we could support parents to apply CBT strategies and principles in their child's day-to-day life. And the advantage of doing this is that we could work quite efficiently with parents using a guided self-help type approach. So in the traditional form, we give parents a book where they read the information that they need, and then the therapist is there to help them to sort of keep working through that material. There are audio versions of those books now too, so working through the written or audio material, really to help parents to individualize the content of that so that they can apply it in a way that really works with their child, because obviously the parent knows so much about what's going to work well, what might not work well with their particular child. The therapist might also rehearse some of the key skills and strategies with the parent so the parent feels well prepared, and also importantly help the parent to problem solve any challenges that might arise along the way. So in our first trial, we compared this approach where the clinician's input took about 5 hours of working with the parent to help them to support their child. And what we found that was after just those 5 hours, we found similar recovery rates to what had been found in the previous meta-analyses, which included much more extensive treatments. And actually by the 6-month follow-up, about 3/4 of the children were free of their primary anxiety disorder. So really good outcomes from a much briefer treatment. And on a broader measure of clinical global improvement, we saw really good outcomes across the board, which were very clearly different for the outcomes for children who didn't receive a treatment. And really importantly, the feedback that we had from parents was really positive. So a couple of quotes here from some qualitative work. One parent said, "Knowledge is an important thing. The more you have, the more helpful you can be." And another parent highlighted that it's empowering for parents to be given the tools to come up with a solution for their children. We went on to do another randomised controlled trial in routine services across Oxfordshire. And what this showed, and what's shown in this graph here, was that there was a very high probability of the parent-led CBT approach being cost effective compared to another brief treatment. In this case, we looked at solution-focused brief therapy. Both treatments have good outcomes, but we had particularly good cost savings in the parent-led CBT arm. So across these trials, this gave us good evidence for both clinical and cost effectiveness of parent-led CBT. So at that point, we worked with the training organisations for children's wellbeing practitioners and education mental health practitioners to help them to train up their new cohorts in this approach. And that's now widely applied across those training courses. We also made the manuals, therapist manuals, freely available, and we established a NHS Future Collaboration workspace for sharing manuals and materials for clinicians to make everything as accessible as possible. And the books for that parents use are available through libraries, and many teams were able to come up with arrangements with libraries to minimise barriers to that as well. However, we were still very aware that a sort of book-based approach, which does actually involve parents having to read quite a lot of material or to listen to it on an audio version, is still, introducing a number of barriers potentially for some families. And 5 hours is still a reasonable amount of time for both families and clinical services to be able to provide. So we were really keen to think, well, how can we make this more accessible and continue to overcome potential barriers? So we worked really closely with parents and children and NHS clinicians to develop an online version of this treatment. And so our recent work, we've been making use of this a lot, and really are hoping that it will be a way for us to implement this approach even more widely. So we just completed a large randomised controlled trial called COCAT in NHS trusts and local authorities and voluntary community sector organisations across England and in Northern Ireland. And we had 444 families in this trial. And essentially what we were looking to establish was, could we reduce the amount of time that it took to have the treatment further without compromising outcome? And so what we found was we could really reduce the amount of time it took to deliver the treatment. So that is in terms of both commitments for clinicians and for busy parents. where this Aussie online support and intervention arm with therapist support took about 3 hours, whereas usual CAMHS treatment, which in many cases was parent-led CBT in the traditional form, took just over 5 hours. So it was almost reducing the amount of time it took to deliver the treatment by half. But what we found was we could do that without compromising outcomes at all. So what you can see here is the middle line shows you the line of no effect. And if the little diamonds are on that, it means the outcomes are basically the same. And what you can see is our parent reported primary outcome. The results were almost exactly the same across those two treatments, despite the fact one was a lot briefer in terms of clinician and parent time. And actually, if anything, on the child report, it's somewhat favoured the new online approach. And encouragingly, feedback from both clinicians and parents was really positive across both of those arms. So we were really pleased that parents and clinicians were happy with the traditional approaches they were delivering in their treatments, but also equally happy, giving ratings of 8 out of 10 for the new online approach. I think sometimes people worry, well, families feel they're being fobbed off with a sort of brief treatment, but this certainly seemed that wasn't the case, that they got equally good outcomes and were equally satisfied. And some really nice feedback here from parents. So one parent here said, I'm a complete techno idiot. I'm not smart or savvy at all when it comes to tech. And if I can do it, anybody can do it. And I think that was really a result of the co-design process that we went through to make sure this was simple and easy to use. We also obviously wanted this to be flexible, and parents certainly suggested that was the case. So one parent said, I could just log into it any time that suited me. So even if it was midnight and I was sat in bed, I could still say, right, I want to get this done now. Or another parent said, I was washing the dishes and listening to it. The fact I can come back and read the things again, I can download them. That was very good. And finally, this approach is all about empowering parents to be able to support their children when they need some additional help. And in the last quote, you can see a parent said, I feel confident enough now that I now have the tools that if this happens with anything in life, not just the person receiving the treatment, for myself, for my other child, it's changed my concept on how to deal with life as well. And that was really wonderful to hear, and actually fits with what we hear from a lot of families about wider benefits beyond child anxiety. We also heard from clinicians who talked about the flexibility of the approach from their point of view. Here, a clinician said, I can book more cases in and I can be much more flexible with them. So that's been helpful. Another clinician said, I feel like a lot of responsibility is lifted from my shoulders because I know the information that parents read is good quality and accessible, and I can check that they've understood it. And just comparing this new approach to our sort of more traditional parent-led approach, here a clinician said it's so much easier to use than going through a book. You know what the parents have looked at, you know that they've read that information and that they've digested it. Before you even speak to the family, you can look at the routine outcome measures. So clinicians can see parents and children's progress throughout. After finishing that trial, we have been rolling out this online approach in routine practice. We have about 800 or so families who are on the system, and over 200 have finished. And what we've been really encouraged to see is that the outcomes that we're seeing are very much comparable to what we saw in that clinical trial. So here you can see outcomes from an early module to a later module on the child anxiety impact scale, which is about the degree to which anxiety interferes with the child's life, and also a global measure of outcomes, where a higher score means a more positive outcome. And just looking at a couple of other measures here, one that potentially is quite easy to relate to is the goal-based outcomes. So here, parents identified 3 goals for their child's improvement and rate them on a scale. And you can see here that the substantial changes in those with very large effect sizes on those bespoke measures that relate to children and parents' individual goals. And also, really importantly, we have seen really high levels of satisfaction from parents across the modules, equally good, if not even better, in routine practice as this is carried on outside of the research trial. So that gives us sort of a bit of a summary of some of the background research and the research we've been doing recently to take this forwards. We're now working closely with a company called Koa Health, who are helping us to really try to implement the online program at scale outside of our research studies, because we are really keen to try and make the most of the potential additional advantages that this may bring for some families. But we've also got a lot of work going on to continue to understand the facilitators of successful implementation and to make sure we achieve good outcomes. So we've been really delighted to be able to work alongside this MHIN project and help support the projects that we're going to hear from soon. And we're hoping to continue to work with them and do some wider work to understand how we continue to maximise good quality implementation, both in clinics and schools. And we have projects, for example, looking at how we could further increase access, for example, through school-based screening. We also are working on adaptations, particularly of the online programme for younger children and a more prevention purpose for autistic children with anxiety problems, as that is a group that we are very commonly approached about and asked if we have tools for. We also are in the process of developing the approach for children with obsessive compulsive disorder and also selective mutism. And we're really keen to hear from you about other areas where this kind of parent-led approach, where we're supporting parents to help their children, might be a good place to focus. So please do share your thoughts on that. And I'll stop there, but thank you very much for joining us today, and I'm really looking forward to the rest of the talks.
Many thanks for that, Kathy. And I can see in the question section there's already several questions for you, so we'll do our best to respond to those as we go along. Okay, great. So our next speaker is Dr. Catherine Berzins, who's going to be talking about an implementation study that has been done with parent-led CBT in the northwest of England.
Thanks, Daniel. Hello, everybody, and it's really nice to be here today to talk about this work. So my name's Catherine Berzins. I'm a Senior Research Fellow with the Applied Research Collaboration Northwest Coast, based at the University of Central Lancashire. And on behalf of our team, I'm going to give you a brief overview of the research that we've carried out evaluating the implementation of parent-led CBT in Cheshire and Wirral Partnership NHS Trust. Now, the aim of the study was to evaluate how parent-led CBT has been implemented via the mental health support teams with no particular implementation support. So I suppose a bit of a snapshot of what happens when an intervention is released into the wild, so to speak. Not that I'm implying that Cheshire or Wirral is a particularly wild place, of course. So the way that we set out to do this was to do interviews with trust staff involved in the intervention, interviews with parents who had received parent-led CBT, and also to try and collect some routine trust data to provide us with some context of what was happening in the trust. The theoretical approach that we used to underpin the study was the Consolidated Framework for Implementation Research, which is commonly known as the CFIR. And this is a framework that prompts researchers and implementers to look at 5 domains. These include the intervention features, so what it consists of, the inner setting, which for us was the MHST, the outer setting, which in this case was the wider trust and the services surrounding the MHST, the individuals that are at work in this setting, so the practitioners and the parents, and their obviously the variety in their characteristics, and then the processes used to implement an intervention, such as planning, reviewing, and adapting. And although the project was carried out as a service evaluation, it was still reviewed by the University of Central Lancashire Research Ethics Committee. Next slide, please. So the project was led by a small research team collaborating with the wider MHIN Project 2 group, staff from the Trust, and our ARC Northwest Coast public advisors. Our public participation and involvement was primarily sought through our ARC public advisors who've been involved in the study throughout, and the kind of things they've done with us included reviewing our research plans and our public-facing documents to make sure that they were comprehensible to parents and practitioners. We also carried out a consultation group with some parents from the Trust. Next slide, please. So in terms of findings, as is often the case with these kinds of studies, things didn't quite go to plan. We did manage to interview 10 practitioners that were involved in the delivery of parent-led CBT, mostly people directly delivering it, but some managerial staff too. We only managed to speak to 2 parents, because fewer than anticipated parents had actually taken part in the intervention, and it proved very difficult to access those that actually had. So because that's such a small sample, I'm just going to talk about the data that we collected directly from practitioners today. We also encountered some limitations with the data that the Trust collected, in that it lacked detail about which interventions were actually offered. So it was quite difficult to use that to get more than just a broad context. But our data from the practitioners, was really in depth and rich, and we had some, really interesting conversations with them. So that's what I'm going to go on and talk about now. So firstly, the features of the intervention itself. And one of the things that people talked a lot about was the mode of delivery. And this goes back to what Kathy's just been telling us about how the intervention can be delivered in numerous ways. Now, our practitioners had experience supporting parent-led CBT with both the book form and the online format had just started to be introduced. So we had that comparison. The book was often seen as quite daunting in terms of the volume and the reading ability that was required of parents to to work with it. But on the plus side, it was seen as being more easily referred back to, as a physical object. And the setup also offered longer support sessions for parents with the practitioner, which was thought to lead to a more developed therapeutic relationship. I've put a couple of quotes on the slide describing this. So one of the practitioners saying that they prefer face-to-face and feeling like you can develop more of a relationship with the parent in that setting. When we looked at the online delivery, it was seen as less personal. There was a less developed therapeutic relationship, but it was much more efficient for practitioners to support, and particularly in this unavoidable context of wider service pressures, which so many services are experiencing these days. And it was also much more flexible for parents to fit in with their other commitments. And I think the quote here illustrates that, with a practitioner saying that the time that they save referring parents onto the online delivery rather than face-to-face means that they can see more parents overall. So, the admin or the parents and children that they can see in that time, is really important to them. Next slide, please. So in terms of the supporting materials, they were often perceived as too complicated. So practitioners had started to develop their own. And this is a really interesting feature of implementation, when people start to adapt things, and kind of perhaps move away somewhat from what they are supposed to be doing. So some of the examples that we had described included people taking snapshots of particular pages of the book, and somebody had developed their own sort of visual model of the way that the intervention was supposed to work. So they'd said that we've got a more simplified model that we show parents, and they find that easier to understand. But the intervention was generally seen as improving parents' knowledge and confidence. And I think this echoes what Kathy's just told us, and that increased knowledge and confidence really increased people's ability to better respond to their child's anxiety. So people, practitioners saw parents, once they knew how to manage these worries and fears and understood what was happening, having that sort of psychoeducation understanding, that was a really good start to help people start to deliver the strategies, the CBT-based strategies to support the child. Next slide, please. So this, thank you, it's that one, thank you. So this increase in knowledge and confidence led to really positive feedback from practitioners about the effectiveness of parent-led CBT if parents were able to engage and put the time and energy into the intervention. And practitioners had seen some really big differences in people's lives as a result. Some quotes here saying that, it's got really good outcomes and it's made big positive differences. And although I'm not going to talk in any detail about the feedback we had from parents, the parents that we did speak to, I think they'd been motivated to speak to us because they had, it had made a huge difference in their lives and the lives of their, not just the child that they'd originally been referred to, but their other children as well. Next slide, please. So in terms of the features of the setting, one of the things was around referrals, and practitioners felt that self-referral was becoming much more common within the trust, and this was a positive move in their opinion, because previously they had the situation where schools were referring parents that they thought would benefit from parent-led CBT, but that had not always worked because these parents weren't necessarily ready or able to engage with the intervention. So although self-referral obviously mitigates that issue to a certain degree, it also meant that there were some concerns that there were people that aren't able to commit to the required level for this intervention might be being left with unmet needs around children's anxiety. And the quote there saying that schools were giving us a ton of referrals for people that they thought should go on the course, but then when the practitioners actually speak to parents, they just weren't interested. So in terms of how the intervention fits within the MHST service, it was seen as fitting very well. But again, we came back to the online provision being seen as a better fit, again, due to these wider service pressures. And one of the quotes here saying, you know, especially because time-wise, it means less time for us on the intervention, the work being pushed back onto the parents, and we're just there to help troubleshoot. We were also interested in whether there are any issues around safeguarding with parent-led CBT, but it was very much not seen as an issue, with the practitioners that we spoke to saying that working with children with mild to moderate mental health difficulties didn't often raise safeguarding concerns. Next slide, please. When we looked at the characteristics of practitioners, one of the things that came out was that the training that many practitioners had received in providing both this and other interventions had obviously, you know, unsurprisingly been disrupted by COVID over recent years. And this had led to people doing a lot of training online in a kind of self-directed way and with minimal access to more experienced colleagues and the kind of informal support that you get from working, you know, physically in the same offices as a team. And some quotes here about, you know, some of the difficulties around training. And one of the practitioners saying, I suppose the training was really just do it, trial by fire. So, you know, that had been quite daunting for some people who had come through that time doing their training. But this situation was now seen as having stabilised, and more recently trained practitioners had that access to more experienced colleagues, were able to shadow people, that kind of thing, and benefit from that informal support. Next slide, please. There was some interesting things around terms of preference with practitioners, and many practitioners seem to prefer to offer triple P, which is a different type of intervention. And this was due to the fact that they could run it as a group, and they also like some of the supporting video-based resources. So we found that practitioners had more experience of this intervention than they did for parent-led CBT that we were looking at. And there was also some kind of concern that the practitioner preference might be influencing the interventions that were being offered to families, and that this might need to be better balanced to make sure that families' needs, were at the fore here, and we're driving the intervention that was offered. Next slide, please. The parent characteristics obviously had an impact on whether they were offered the intervention in the first place. Some practitioners felt that the intervention was tailored to much more middle-class participants than those that they tended to work with. And middle-class was a phrase we heard quite a few times when talking about this. So a quote here saying, you know, it's very white middle class in terms of accessibility, and we don't work in a very middle-class kind of catchment area in our service. And other people talked about the literacy levels required that, you know, we've mentioned before, the inaccessibility for parents from different ethnicities, and also the fit within parents' other commitments, you know, their work and, you know, parenting other children, that could make it more difficult to free up the necessary time. Next slide, please. There was also an issue commonly described in that practitioners thought that parent-led CBT could result in some parents feeling judged, perhaps feeling blamed for their child's anxiety. Somebody saying here, if it's not delivered delicately, it can come across as quite blamey by its nature, just from the model, and might leave some people feeling attacked or feeling blamed. So practitioners felt that they had to tread very carefully around this to make sure that parents didn't feel like that. There was, next slide, please. There was also, one of the differences between the delivery in person and, sorry, could you go back a slide, please? Thank you. the delivery in person and the delivery online, and that there could be a stigma around attending to take part in the intervention face-to-face if it was a known CAMHS location, that people might not be keen to be seen attending that service. So another advantage of the online delivery was that it resolved that problem. Next slide, please. There were also conflicting views around how well the broader service within the Trust was aligning its support for children with neurodiversity issues and its support for children with anxiety, where, as Kathy said earlier, there's a lot of overlap between the two groups. So some practitioners have told us about parents being initially referred for parent-led CBT, but then being kind of withdrawn from that when they started receiving specialist support for neurodiversity issues. So we felt that was something that needed to be clarified. Next slide, please. But overall, most practitioners believe parent-led CBT to be very effective once parents were engaged with the intervention, and that simplifying and reducing the content would make it easier to deliver and also make it more accessible for more parents. And furthermore, it was just this place within the overall broader services required a bit of clarification in terms of how it fits in with other interventions, as I've already said. But overall, it was seen as a very important part of the MHST offer. Next slide, please. So we're currently writing up our findings for publication, which will hopefully be available, over the next few months. And next slide, please. The final slide just really just credits all the people that have been involved in this evaluation. It's been a really interesting project to be involved in and be part of this network, and it's really nice to have the opportunity to share some of the findings today. And I hope they give people some food for thought. So thank you very much.
Many thanks, Catherine, and yeah, very thought-provoking, and I'm sure we'll get to touch on some of the issues you've raised in our panel discussion later on. So I'm going to hand over now to our other implementation team, who were based in the east of England, who've also worked with parent-led CBT, but as you'll hear, they've sort of taken a somewhat different approach to implementation, and yeah, look forward to hearing more about this. So over to you, Tim and colleagues.
Thanks, Daniel, and thanks for inviting us to come along to tell us about our Working on Worries project. So we're going to use the next kind of 30 minutes to let you know about the Working on Worries project, which is essentially an implementation project aimed to support primary schools and pastoral workers in primary schools to implement and deliver parent-led CBT approaches for child anxiety difficulties in the two formats that Kathy mentioned earlier, so the online support intervention approach and the face-to-face helping your child approach. I'm Tim Clark. I'm one of the co-leads. I'm a clinical psychologist by background, and really interested in how we can use implementation science principles to embed evidence-based practice to our populations in need. Next, a couple of slides, please, Luke. So I'm part of a larger team. Natalie, Luke, and Theo are with us today. But we've had a wonderful team working on this project. So first and foremost, I wanted to thank everybody for their involvement, because without them and the wonderful team that we've had, this project wouldn't have been as successful as it is. So essentially, our project aims were fairly simple. It was to reach primary schools and pastoral workers in primary schools to support them to deliver and implement parent-led CBT approaches and improve access to this evidence-based approach. It was to optimise and guide the implementation of parent-led CBT approaches in Norfolk and Waveney primary schools. We wanted to optimise delivery through the use of children and young people's mental health professionals by them working directly with pastoral workers and supporting them across our system. And therefore, we wanted to further develop those cross-organisational relationships that we deem so important in implementation. And then, as it's an implementation project, we evaluated the implementation outcomes to inform future work in sustainability. So we won't be reporting on clinical outcomes in this presentation, but really focusing on how others could implement this approach, perhaps in your areas. This couldn't have been done without Natalie, who's up next to talk about the work that she's led with us in the pilot of this approach. And really, the whole idea came from working with Natalie and the group of primary schools that form the Nebula Federation within Norfolk. So Natalie's going to tell us a bit about the pilot work that informed this approach.
Thanks, Tim. Hi, everybody. I'm Natalie Brown. I'm the Pastoral Manager for the Nebula Federation of Schools. We're a group of 6 primary schools, sort of just north of Norwich. And prior to working on Worries project, Tim and I and a few other wonderful people worked on a pilot study which was run across our schools. The reason for the pilot is that we'd identified there was just a real need to kind of move away from crisis management and move back towards early intervention and prevention. And in primary schools, we've seen a huge increase of children with anxiety. And whilst we are able to support them in many ways, there is a limit to what we're able to provide. So when there's sort of this huge increase in anxiety, and then it gets to a point where it's sort of really impacting children's day-to-day life, we're left with the only option, which was to make an onwards referral and wait until an external agency could provide some specialist support for that child or children. So being able to kind of offer this evidence-based intervention at a really the earliest possible opportunity fits with our holistic approach to supporting children and families. So during the pilot, myself, the entire pastoral team and some other members of our school staff were all trained to deliver the intervention. And then we worked with some families where anxiety was really kind of impacting children's day-to-day life. So these are children across our schools. And then the outcomes were fully evaluated, and some of them are on the next slide. Thanks, Luke. So overall, there was a reduction of parents and carers reports of the impact that anxiety has on children's lives. And parents and carers perceived the programme as being easy to follow. And school staff also felt that the programme was acceptable and felt confident in delivering it. We did have some support as well from Ormiston families and their kind of guidance around kind of delivering a clinical intervention in school, because that was something that was definitely new to us. And then there's a lovely quote from a parent who said, talking about their child, they're now much more confident and more independent. They've managed all the tasks that were set out, which at the time seemed like a mountain to climb. And as a result of achieving the goals set out, they're really happy and much more independent. They're able to be themselves and for short periods of time, and they're happy to go to friends without me always being there by their side. So it just highlights kind of how amazing it is to instill that sense of confidence and independence throughout this. I'm just going to hand over to, I don't know, Tim, Luke? Tim? Thank you.
Thanks, Natalie. And next slide, please, as well. Thanks, Luke. So following the successful pilot, we knew that we wanted to expand this approach even further to more primary schools across Norfolk and Waveney. So we were so excited when we were selected to be a site for the Mental Health Implementation Network funding through MHIN, as Cindy described earlier, to expand this work across further primary schools in Norfolk and Waveney. We learnt a lot in the pilot, as Natalie's kind of suggested. We knew it had a good proof of concept, but we knew that we needed to do more to optimise the implementation of this approach across further primary schools in our region. So we went back to the kind of literature around implementation science, and as Catherine was alluding to earlier, there are many kind of implementation science frameworks and theories which help us to kind of optimize implementation of an intervention or innovation into practice. We chose to use the EPIS framework, so exploration, preparation, implementation and sustainment. A lot of that kind of exploration had already been done by the core MHIN team to think about parent-led CBT and how it fitted the needs of children and young people, particularly with ongoing cases of anxiety difficulties. So we then used the EPIS framework to further think about how we could introduce implementation strategies, how we could prepare to support pastoral workers in primary schools, and most importantly, we started to think about sustainment, scalability and spread right from the beginning. Next slide, please. So we used the EPIS framework to help us guide our kind of implementation strategy, if you like. So under the reference of kind of preparation, so within that preparation phase, we knew that having a really great core project team to support the coordination of this programme of work was going to be absolutely key to implementation. I've already bigged up Natalie, but to big up Natalie even more, that kind of school representation from a pastoral worker perspective was especially important, alongside also our parent carer representative, Rachel, who unfortunately can't be here today, but has been so influential to our work as well. We've also had wonderful colleagues such as Luke and Theo that you'll be hearing from later. So having that kind of core project team we knew was going to be key in helping us to prepare for scale up and implementation across Norfolk and Waveney. We also wanted the project to be owned by the system. So this wasn't just a good idea that a project team was leading on. So we set up a stakeholder steering group, which had representatives from parents and carers to our integrated care board, to our provider organisations and local authority. Essentially they took on a kind of shared accountability and ownership for this project. So it was a system-owned piece of work. We also knew with sustainability in our minds that we needed to probably invoke a train the trainer approach, so that we had local children and young people's mental health practitioners trained up in training of parent-led CBT. And that included our children's wellbeing practitioners, educational mental health practitioners, educational psychologists, Natalie and some of her team. So we had a really great core group of trainers. We also wanted to focus our school recruitment on those that weren't accessing mental health support teams at that particular point, because in theory they should be already accessing parent-led CBT approaches. So we also looked at the wider determinants of poor mental health and started to stratify our approach to identifying schools that would be offered this opportunity first. And we also thought about how we need to make it a really nice experience for pastoral workers to be trained. So we ordered lots of the pink Helping Your Child books. We provided nice training venues. We provided lunch. We printed out intervention manuals. We tried to make everything as easy as possible for pastoral workers to implement this approach. And then most importantly as well, we identified an implementation lead in each school, which sometimes was the pastoral worker, but sometimes it was a member of the senior leadership team. And we developed an implementation planning tool based on the EPIS framework to ensure that that implementation lead could support and overcome any implementation barriers that were identified. Next slide, please, Luke. Moving on to the implementation phase, we provided lots of resources, guidance and toolkits to schools around things like identification and recruitment of families and children, and also routine outcome measures, training and access to an online outcome measure system called POD. We also knew that we wanted to maximise adherence to the manual and to the intervention. So we started to offer things that we called collaborative learning and support sessions, which ran fortnightly, and they were facilitated and led by our trainers, essentially, so those children and young people's mental health professionals in the system. And that was an opportunity for pastoral workers to come and talk about anonymously some of the cases that they were working with, and to ensure that there was adherence to the manuals. As I said earlier, we focused on sustainment from the outset. And that included thinking about local trainers versus external trainers. To begin with, we had an external trainer, the wonderful Chloe, to support us from Kathy's team, but we also trained up an army of local trainers. That system-wide ownership was key. We worked hand in hand with our commissioning colleagues to ensure that this was a programme of work that fitted with their priorities. And of course, we focused our evaluation on implementation outcomes, which were informed by Proctor's implementation taxonomy. And we're going to tell you about some of those implementation outcomes now. So over to you, Luke.
Thanks, Tim. Sorry, I was just struggling to unmute myself there. Hi, everyone. My name is Luke Wrigley. I'm a research assistant psychologist for NSFT. And as Tim said, I'm just going to go through some of the outcomes and project activity, sort of as they relate specifically to the preparation phase of the project. So as Tim outlined, one of our strategies was to form a system-wide stakeholder steering group with representatives from across the system. So this group, over the 12-month implementation period, met a total of 8 times. And members of this group really played a key role in different aspects of the project. So things like thinking about our approach to school recruitment, specifically identifying local education networks that we could go through to promote the project, but also things like championing the approach within their respective organisations and helping us to define the scope of the current project. Other key activities included things like developing the evaluation plan for the project, informing dissemination activities, and then also thinking about sustaining the approach beyond the project timeline. The feedback we got from members of the steering group was largely positive, particularly with regard to how fast the project was able to progress in terms of recruiting and training school staff. And they also felt that being able to sustain this approach in the long run would help to empower schools to intervene proactively when supporting children, but also help to build those relationships between schools and mental health services. One comment we got from members of the group was that they felt a greater connection to parent and carer stakeholders would have been beneficial. So while we did have parent-carer representatives within this group, a lot of them were parents of children for whom parent-led CBT might not have been a suitable intervention. And those members reported feeling more like observers than stakeholders in the project. And so moving forward, that's something important to consider is potentially membership of parents and carers with experience of parent-led CBT, or potentially finding ways of linking our parent-carer advisory group in with the steering group a bit more. Moving on now to think a bit about the train-the-trainer model that Tim mentioned. So throughout the project, we trained 22 local mental health practitioners as well as other professionals with between 1 and 4 years of experience of delivering parent-led CBT. So as Tim said, they were trained up to deliver training to school staff and support them as they implemented the intervention. Of these 22 trainers, 8 of them volunteered to deliver training for schools. So their data is represented by the blue bars in these charts. And then just thinking very quickly about attrition. So throughout the project, we had 1 trainer who withdrew prior to attending the trainer training, and then a further 2 who withdrew following the training. And these withdrawals were due either to personal circumstances or feeling that there were competing commitments within their role. So for instance, clashes with university study days. I'm not going to go into all the data in too much detail here, but we have some feedback from the training event that was facilitated by Chloe Chessel. So here we have our pre-post questionnaire, which looks at things like trainers' self-reported knowledge and skills, and their confidence in their ability to deliver training to school staff. And as you can see, what we found sort of pre-post training was that there was an increase in all areas of the questionnaire. This was reflected in our training feedback form as well. So this is trainers providing feedback on the training event itself and looks at things like whether the content met their expectations and was presented at the right level, whether the training activities were viewed as being helpful. And again, we saw quite positive feedback from that training that was provided by Chloe. Towards the end of the project, we conducted focus groups with our trainers, and some of the key insights that came out about the project were, first off, that trainers felt their participation within the project fit quite well with their usual role. So the majority of our trainers were CWPs and EMHPs, and they felt that this model of promoting early intervention and supporting schools to enhance their wellbeing offer fit quite well within their services. However, one point that did come up was that they felt that sometimes the time they dedicated to the project wasn't always necessarily recognised by their service leads or by their line managers. In terms of their experiences of actually delivering training for school staff, the trainers felt that having diverse perspectives from different trainers helped to enrich the training. So for instance, having different trainers perhaps from education system or from mental health services was beneficial both for school staff who attended, but also for the trainers as it gave them an opportunity to network with people from across the system. They also identified the benefit of having trainers who had experience of delivering the intervention themselves, because they felt that allowed them to draw on their real life experiences from their own past cases and illustrate how the strategies from the intervention, could be applied to different presentations and different cases. And they felt that often these parts of the training really sparked engagement from school staff and helped to ground the training in reality. A final sort of component of our training events was this idea of co-delivery. So for all of our training events, we aim to have 4 trainers who facilitate the sessions, and we divide them into pairs to deliver different sections. And they fed back that this co-delivery model really helped to put them at ease, as they didn't feel like there was a massive spotlight on them, but also felt that being able to co-deliver helped to promote sort of a conversational presentation style, and also keep the training a bit more dynamic by introducing different pairs of trainers for different sections of the training. Moving on now to look at school recruitment and our school training events. So in total, we trained 107 school staff from 78 primary schools across Norfolk and Waveney, and that was done across 3 rounds of training. So school staff came from quite a variety of roles, but included things like pastoral support staff, family support staff, SEND staff, some class teachers and TAs, a few school heads, and then as well some other non-teaching staff. As Tim mentioned as well, we set out with a targeted school recruitment strategy that was based on levels of deprivation and access to mental health support teams, which left us with a list of 23 schools that we aimed to recruit. And throughout the project, we recruited 10 of those 23 schools. Following slow uptake from our target schools near the beginning of the project, we actually decided with the steering group to expand our recruitment strategy to include all primary schools in Norfolk and Waveney who didn't have access to mental health support teams. However, one of our project aims, or something we were conscious about, was reducing health inequalities. So what we've done is we've analysed all of our participating schools' deprivation indices based on their postcodes. And what we found is that across all of our schools, there are no significant differences in the deprivation indices of WOW schools and the Norfolk population. That being said, when we looked at Wave 2.2, which was our most recent round of training for this phase of the project, which took place in October, we saw that we did actually recruit fewer schools in the most deprived areas compared to our earlier rounds of training. And we're not entirely sure at the moment what it was about our recruitment strategy that led to this. In terms of rurality, we found that 62% of our schools were classified as being in rural locations compared to 50% of the Norfolk population. And we believe that the increase in uptake from these schools might reflect the needs of these schools in light of poorer availability of mental health services in these locations across Norfolk. In terms of school attrition or school staff attrition throughout the project, we had 29 school staff who withdrew from the project prior to attending training, and then a further 16 who withdrew following the training. For those who withdrew prior to the training, the main reasons given were a perceived lack of staff capacity to actually implement the intervention, clashing commitments within the school, so things like Ofsted inspections, other school events, or staff being out on other training. And then unfortunately, one of our training events did coincide with a school strike, so that also had a bit of an impact. For those who withdrew following the training, this was due to either a change in role of trained staff, staff turnover, where trained staff would leave the school, trained staff feeling unable to get protected time from senior leadership team, or trained staff feeling a lack of confidence following a trial run of the intervention within their schools. Now, again, I've got some data from the training events that I won't go into too much detail about, but again, here we've got a pre-post questionnaire, and we saw an increase in all items, with the exception of staff's perception of how possible it would be to implement the intervention within their school. And it's possible that this might be linked to the fact that the other item, which is time, so staff's perception of whether or not they have the time to implement this, remained relatively low compared to other items on the questionnaire. In terms of the training feedback from schools, all of the training events were positively received. And by collecting training feedback, we were able to iteratively implement changes to the training events. Most notably, what we did was split our training for the Helping Your Child format and the online Aussie format, because there was feedback quite early on in the project that covering both of those formats in the same training event was a bit too much. So that's now been spread out over 2 separate events. And then finally, to wrap up the preparation phase of the project, Tim mentioned our implementation planning process. So following training, the implementation lead from each school was invited to meet with a member of the core project team to develop a school-specific plan. So throughout the project, we had 39 schools who engaged in this planning process. And of those schools, 76% rated the planning process as being either helpful or very helpful. With one member of staff in particular saying that they felt that this provided them with an excellent opportunity to reflect on the process of developing and implementing the intervention and helping them to consider the different barriers and opportunities within their school. So generally quite a positive process, but there was feedback from some of the schools that actually the plan was then difficult to execute, mostly due to the dynamic nature of school life. And they suggested instead that a continuous or more fluid approach to implementation might be more suitable to a school context. That's everything on the preparation, so I'm going to hand over now to Theo to talk about the implementation phase.
Thanks, Luke. Hi, I'm Theo Koda. I'm also a research assistant psychologist on the Working on Worries project. I'm going to talk a bit about the implementation outcomes. Next slide, please, Luke. So as of December 2023, we had records of 43 Aussie cases across 16 schools and 24 HYC cases across 13 schools. It is important to note, however, that this data is drawn from demographic capture sheets that were returned by the schools themselves. And we do know from the Aussie platform that there were actually a further 20 Aussie cases. And based on this, we suspect there were also further unreported HYC cases. Next slide, Luke. So Aussie was by and large the preferred format for the schools. Based off a survey distributed to this trained school staff, family preference and staff capacity were the main influencing factors. And feedback from a focus group we did with these school staff members fed back that Aussie was felt to be more time efficient and flexible for parents and carers, and that parents and carers could complete the intervention training and sort of things in their own time rather than having to come to a set meeting point and meeting with school pastoral staff. Next slide, please, Luke. So these focus groups also highlighted a number of facilitators and barriers to delivering the intervention. The primary facilitators were that school staff felt that they had prior existing relationships with parents, carers, and children, and this enabled them to more readily identify who the intervention would be appropriate for. The main barriers that were identified were staff capacity and low time capacity as well, and the need to be flexible and accommodating parent care needs. This combination made it difficult to deliver the intervention to as many people as they would hope to deliver it to. However, it is important to note that the inherent time efficiency and flexibility in the Aussie platform did help them to overcome a number of these barriers. Next slide, please, Luke. So a key part of our implementation strategy was the provision of supervisory class sessions. These were held fortnightly, as mentioned earlier by Tim, and facilitated by WOW trainers. The main purpose of these sessions were to provide a location for school staff members to have questions answered they might have, and also to learn from other school staff members' experiences. Next slide there, Luke, please. Unfortunately, during this initial phase of the project, attendance at the class sessions was quite low, with school staff only attending 26.4% of the sessions they were eligible for. There were a number of reasons for this: competing priorities within schools, poor time capacity, as well as safeguarding issues that came up on the days of the sessions. Feedback from the staff who did attend these class sessions was largely positive. They really valued the facilitator's expertise in the intervention and also appreciated the opportunity to learn from other school staff members. However, they did note that the low attendance detracted from this learning opportunity. And facilitators were also concerned about the low attendance at the class sessions. They felt that it could lead to ineffective and unsafe practices, as well as the intervention being offered to families to whom it was not appropriate. And they worried that these families would then be dissuaded from seeking future support from other interventions. Next slide there, Luke. So as a result of this feedback, we have implemented some changes to the class sessions in our next phase of the project. They are now held once every half term, although facilitators are able to be contacted between sessions. In addition, a class agreement was distributed to each trained school staff member, as well as a member of the senior leadership team at the schools, with the expectation that attendance at the class sessions would occur. And school staff members were informed that if they repeatedly failed to attend class sessions, their participation in the project would be ended, and that would also cost them the ability to access the Aussie platform. I'm now going to turn it over to Tim for some discussion on the sustainability of the implementation.
Thanks, Theo. Thanks, Luke. So just to finish on, we also had our eye on sustainability right from the outset, and we used another type of kind of implementation framework called knowledge process theory to start thinking about how this intervention could be considered as a normal part of a pastoral worker's normal practice within their schools. So we used normalization process theory to essentially assess the outcomes of this. 32 of the 45 staff viewed delivering parent-led CBT as a normal part of their role, and it fitted with their usual work, and they were able to integrate it into their offers of support. And as Natalie often talks about, it was part of their toolkit. It was another tool in their toolkit. Those that didn't, though, it was mainly because they weren't working in a specific support role, or that they felt unable to implement it due to lack of time and capacity. And that's something that we heard quite a lot. So in order to sustain this, we need to continue to think about continued funding, protection of time in schools, continual kind of professional development and training, ongoing class sessions. And as Theo has just mentioned, we were very iterative in our approach, and we've changed that model now, and further support from our kind of coordinating team. Next slide, please, Luke. So we've also been thinking about extension and expansion. So even though the MHIN part of this project is now kind of over, we have been working really closely with our integrated care board and our local commissioners and system to think about the extension and expansion of this program in Norfolk and Waveney. We were so thrilled with its progress that we really wanted to sustain this work and expand it. So we've got 2 programs of expansion now, and this is really thanks to further funding from our integrated care board. The first program is the extension of the WOW project that you've just heard about. So we're reaching even more pastoral workers, even more schools, even more families affected by anxiety. And we're also expanding out to MHST primary schools and working closely with our MHST colleagues and clinical leads to support primary schools who are also served by an MHST. And Programme 2 also looks to expand training for online support intervention, so Aussie to our CWPs and our EMHPs across Norfolk and Waveney. So again, further expanding access to this evidence-based intervention, and both of those programmes run up until 2024. Next slide, please, Luke. And just finally to say that already within this expansion, and mainly thanks to the wonderful work of Luke and Theo and others, we've identified 7 further new trainers. We've already delivered 2 additional rounds of training with a 3rd planned for June. So we now have 158 staff trained in this approach, 109 primary schools out of 513 in Norfolk and Waveney, and already over 110 Aussie cases in action or completed by participating schools, plus a number of further helping a child face to face. So this really is improving access to evidence-based interventions. We're going to leave it there for our presentation for now. We've got some reflections on our programme of work that we're going to share towards the end of this webinar together with Becca and colleagues. So it just leaves us to hand back to Daniel and say a massive thanks as always to our wonderful Working on Worries team. Thanks, Daniel.
Many thanks, Tim and colleagues. Really impressive work in its depth and scale. So now we have an opportunity to actually hear from parents and caregivers who have experienced parent-led CBT in various ways and contributed to our project. So I'm just going to hand over to my colleague, Lucy Gallagher, who is the Patient Public Involvement Coordinator for MHIN. And she is going to introduce some videos that we have with some first-hand testimony from parents and carers. Lucy.
Thanks, Daniel. Yeah, so I'm Lucy. I work across the mental health implementation network across all the 3 projects. And I'm just here today, like Daniel said, to introduce our wonderful PPI colleagues in East of England and North West Coast. Rachel, who you'll be hearing from first, unfortunately couldn't be here today. And then we're going to go on to Farheen Yamin, who is an expert by experience from the North West Coast region. And then we'll go back to a video from Rachel, who's going to talk a little bit about her work as the PPI lead. So next slide, please, Fabia.
Hello, I'm Rachel Maguire and I lead the Parent Carer Advisory Group for the WOW project. I'm a peer researcher and a parent with lived experience of supporting my child with parent-led CBT. And I thought it would be nice to start my talk with a video co-produced by some of the parents in the advisory group. There are 2 reasons why I think it's important to share this video. Firstly, it's because the videos are parents themselves talking about the parent-led CBT experience firsthand. It's parents talking about their fears, concerns and hopes regarding the intervention and their overall thoughts and feelings once they've joined the programme and then completed it. Secondly, it's because the video was co-produced by parents who have done the programme for parents and carers invited into the programme. And it's a really nice example of the kind of materials co-produced by our advisory group, motivated by their own ideas with support from me and implemented into the WOW programme by the team and used as some of the core resources that schools can use when inviting families into the programme.
When I was first approached to take part in a parent-led CBT programme to help our daughter with her anxiety, I'd never really heard of it before. I had no idea what it meant. So I had a really good conversation with the pastoral manager who explained exactly what would be involved in the programme, how long it would take, how much time it would take, what I would need to get involved in and what our daughter would need to get involved in. I initially said yes. Once I put the phone down, I must admit I was a little bit overwhelmed and thought, what have I committed to? Have I got time to do this? I know it's the right thing to do, but I just don't know if I've got time. Had a really good conversation with my husband and we discussed it through and we said, no, we need to do this, we need to make this work. We need to find the time because ultimately it will give us tools and it will also change our daughter's future and coping with the anxiety. After going through the programme, it went really well. Our daughter's really improved and has now got the tools to cope with her anxiety. She now no longer has, for example, those tummy nerves as she approaches the school gates every morning. She has the tools and she knows she can do it. She's got the confidence. And if any point these anxiety feelings come, she now has the tools to deal with them and to cope with them much better than before we did this programme. And also as a parent, we have the tools to help to support her as well. So you will have worries, you will have fears, but stick with it and you will get the best outcome.
Our son has struggled with anxiety issues and worries over the years, and we tried lots of different things and nothing really worked. So when we were offered the chance to take part in the programme with the school, we jumped at the chance just to see if this would help us. There's lots of things that you learn on the plan. One of the things for us, I think, that stands out the most is the step plans that you learn about. Our son wouldn't wear a bike helmet or use a lift, and by the end of the step plans he was wearing a bike helmet and using the lift, and he still does to this day, and I don't think that would have been the case if it wasn't for the step plans and the programme. It's been quite life-changing for us. You learn lots of things which you can help your child with, and in turn they can help themselves and hopefully take that forward into the future to help them when they're older as well.
I was asked if we were interested in taking part in parent-led CBT to help with our daughter's anxiety that she was suffering inside and outside of school. Now, the advantage, I think, of accepting this help via the school pastoral team was that the school obviously already knew of all our daughter's struggles with her anxiety, how it affected her at school. So it was quite easy to get things off the ground. You know, they didn't have to ask hundreds of questions to find out lots about her, which perhaps somebody externally would have needed to have done. So that really did help, I think. We also didn't have long waiting lists. I know that if you try and get help elsewhere externally, there is a big wait at the moment for counselling, etc. for children. So that was a massive bonus as well, to get that help quickly when we needed it. I think also some children probably find it easier getting help through their parents rather than speaking to somebody that they don't know. So again, for us, that really worked. My daughter is really shy, so us being able to do the CBT with her after learning how to do it ourselves was a massive advantage. As parents, we sometimes did have different views on whether or not she needed the help, but we did decide to go ahead and give it a go, and we are very appreciative for the help that we got. We're really glad that we did go ahead with it, and I would highly recommend anyone to do this course. It gives you lots of tools, tips and support on how to help your child moving forwards. So yeah, definitely worth doing.
Hello everyone, my name is MHIN. I'm a public advisor in ARC Northwest Coast and participated as an expert by experience. Today, I want to talk about the service offered and one specific approach called parent-led CBT and share my thoughts on it. The NWC project provided a range of services, including workshops, focus groups, counseling sessions, and support groups. These services were helpful because therapy offered a safe environment for discussing the difficulties and creating the skills to cope it. We were able to learn from others' experience and felt less alone thanks to support groups. I was not offered parent-led CBT. However, I understand it is a therapy program where parents learn skills to support their children experiences excessive worry, physical symptom of anxiety such as rapid heartbeat, stomach ache, having trouble falling asleep, or avoid particular events or activities. It is important to remember that there are just general examples and not all the children will experience these difficulties in the same way. A few factors might have affected my choice to take part in parent-led CBT. Accessibility. It would have been much simpler to attend if the program had provided childcare during sessions and allowed for flexibility to scheduling. Stigma. Speaking honestly about treatment might occasionally feel excluded. In South Asian people, mental illness may be viewed as a form of madness. There are lack of awareness about the nature of anxiety and how common it is. This issue may be resolved by providing clear information about the program's advantages and highlighting its regularity. Understanding. It would have been essential for me to properly discover parent-led CBT if I had been given clear explanation about what it involved and how it may assist both my child and me. I had a good experience with the NWC projects, and I think strategies like parent-led CBT have a lot of promise. I encourage you to get in touch with experts and look into your options if you are dealing with similar issues. Recall that asking for help, assistance is a sign of strength rather than weakness. Thank you.
I want to follow up these videos by talking about the importance of hearing from experts by experience in groups like PCAGs. PCAG stands for Parent Care Advisory Group, and the role they can have in the implementation of evidence into practice and what kind of support they might need to help them do that really well. So I feel that with the WOW project, I've been in a great position where I've had one foot in two camps. So I mean, I'm a core team member attending core team meetings, and I'm also the PCAG lead, and being in the core team has been really important for me to stay abreast of core discussions and identify where the advisory group can best help. And being encouraged to bring discussion points from the PCAG to the core meeting agenda has helped facilitate that link between the lived experience side of the advisory group and the project team. So, for example, if the parents bring something up and I think, gosh, we really need to be thinking about this, then I'll add it to the agenda. And because the PCAG are happy for me to record our meetings, sometimes I've played a snippet back to the core team. And I think that has had a big impact. It's been a really powerful way of getting the rest of the team to think, yeah, we want to hear more about this. Part of my job is to recognise which bits are the important bits and organising that into some coherent fashion that can be reported back to the core team. Obviously, I can't just say, right, here's an hour-long meeting and here's everything that everybody said ever. And sometimes it might be something that we've talked about in our core group and I've gone and purposefully asked the PCAG. And I know I can report back to the core group with the answers. So those are the ones that are the easiest, but sometimes a little thread might come out of the conversation in the advisory group that makes me really think, we've not talked about this, but this is so important. And then I can take that back to the core group and we might talk about it and then say, right, we want to know more about this. Let's develop that into a whole separate conversation. Or it might have just been enough to share that with the core team and that's enough for us to then action something off the back of that. But some of the best stuff that's come out of this has been when we've done iterations of conversations, like if we've revisited something or if we have asked a new question that's quite similar, and it brings new insights. So as we've done iterations of conversations over time, well, we've put together a sheet that ended up being called Common Concerns, and it became a resource to give to prospective parents coming into the project. And it was peppered with quotes from the parents and carers. So lots of stuff sort of happens by accident. It's not necessary that we've gone out to seek to create something. Sometimes things just emerge and then I'll take them back to the core group and say, you know, this is really becoming something. Does anybody else feel the same? And so far I've never had anything where people have said, no, I don't think so, I don't think that would be any good, don't spend any time on that. But it's usually nice to arrive at a meeting with an idea that the PCAG have had a chance to think about in advance if they want to. But the flexibility to discuss things within the PCAG and the core group's willingness to take on board these suggestions has been key. And we've seen some actual direct changes to the implementation from what the parent and care advisory group have told us. The Common Concerns document wasn't something one of us had written and then we took it to the advisory group and said, does this read okay? What do you think of it? It had been developed because of the things that they told me. And then I've gone back to them and I've said, what do you think of this? Do you think this would have been useful if you'd had it? And then we've co-developed it together and reworded it, put it in different order and made sure it hits the spot. So, you know, as another example, one of the parents was talking about the difficulty of trying to do the intervention at home and then their child going to stay with grandparents. So we started to talk about blended families and separate households and how to get the main message across about CBT without having to explain the entire intervention to another person. And we've now got a poster of the main key points about the intervention in an easy to read format that parents and carers would like their wider family to know. So if there's a sleepover at a grandparent's house, what are the nice things that they can do to help support the child on a sleepover? And the nice thing about that resource is it went to be co-developed with a member of Kathy Creswell's team at the Oxford University with the PCAG. So it's not just for this project anymore, it's gone further. And obviously there's no perfect way to do this. There's no perfect way to run a parent care advisory group, and members of the PCAG are doing this outside of the commitments. Even if there's a payment, they're mainly doing it because they think it's important. So this is about giving people a reason to keep participating. So I've really learned about feeding back on where they've had an impact. For example, we've added into the training because of what you raised in the meeting, or we've put this together and that's now gone out to the families. Or those quotes we shared at the conference were really powerful and there's a commissioner interested in the project. So it's uber important to let them know about the impact because they're only doing it if they feel valued at the end of the day. it's got to be more than just a conversation about tell me your thoughts and feelings and your experiences, and I'll add them into the project. I'll use them in the project. I was doing a bit of recruitment for my dad's group, and the opportunity came up to offer some resources back into their group. And I think the ethos is it's a two-way relationship. If we're asking people for things, what can we offer back? One thing we've talked about within the MHIN is diversity within the group, and we're making that a priority to address diversity going forwards this year. There are whole groups of people that just aren't included in PPI. And I think that could be because of the time needed to dedicate efforts on engaging different groups, various different groups. It could easily double the time spent on running an advisory group, and I don't think that would be a bad thing either. So just want to say thank you for listening.
Just to acknowledge the contributions then of the parents and the PPI leads who were involved in putting together those testimonials. I'm sure you'll agree with me that they provide such an important kind of complement to some of the more traditional kind of research evidence that has been produced through MHIN and sort of through the types of research LCTs that Kathy has kind of spoken about earlier. So the next slot is sort of, I'd say, kind of a follow-on piece of work that we developed through MHIN. And in the course of the work in the two sites, we realized that we weren't getting the perspective of children, sort of partly because of methodological limitations. And so we have done some work on actually scoping out the available kind of research and practice literature when it comes to involving children and young people in the development and evaluation of parent-led interventions. And Rebecca Noland is now going to say a bit about that work, which I think complements some of the PPI work involving parents.
Yeah, okay, I'll just share my screen, sorry. Hopefully everyone can see that now. Thank you, Daniel, for that introduction to this part of the work. So this part of the work was conducted by both of the project teams and also with some members of the MHIN team. And we did a review of the literature looking at involvement of children in relation to parent-led interventions. So it's really important to involve children. The UN Convention of the Rights of the Child says that children should be able to express their views and their opinions on matters that are affecting them. So particularly in an intervention that's designed in relation to support them, we should aim to involve children in that as much as we can and look at ways that we can do that in an effective and meaningful way. We also know that mental health interventions that are designed for children that aren't developed with their involvement are less likely to be effective. And we know that working with children provides this knowledge that is different to the knowledge that we would get from adults. So it provides new ways of engaging with children, and it also provides new meanings about concepts from a different perspective. So it's really important to think about how to do that. So this was largely a review of the existing literature. We looked at children in the primary school age years, so 14 to 12 years, because that's what the interventions that we were looking at were targeted at. And we wanted to describe the methods that have been previously used to involve children and summarise any findings related to that involvement and make some recommendations for future research and best practice in this area. So as I said, we looked at 4 to 11-year-olds, so primary age group children. We focused only on interventions that were parent focused, and they had to be mental health. And we looked at the 4 common child mental health problems, so anxiety, depression, and behavioural difficulties. And the focus had to be one of those elements of mental health. We involved any studies where children were involved in any aspect. So it could be in the development, it could be in the implementation, it could be in the evaluation of the implementation. And we did look outside of academic literature for grey literature reports of projects that had been done that hadn't been published academically. That resulted in around just under 9,000 articles, and of those we found that 11 met the criteria that we were interested in. So of those 11 included studies, so that's not a large amount of studies. 2 of those were interventions that were universally provided, so all children within a school age group or year group were able to take part and have that provision. And the rest were specifically targeted to specific populations. One of these was with refugee children, and the other was with autistic children. And you can see the different mental health conditions that they involve. So most of them were with anxiety, a number with trauma, and then we had the other categories. So just you can see there on the different programs, there's quite a variety of different parent-led interventions that were included. There was 3 studies around the one that Kathy Creswell mentioned, 2 of which were the online version of that. And then there was 2 studies that focused on trauma, which used the stepped care trauma-focused cognitive behavioural therapy. And another intervention that was a bit different that focused on kind of memories of traumatic experiences. So in most of the studies, 9 out of the 11, children were study participants in the sense that they provided reports of their own well-being. So they filled in questionnaires that measured their anxiety or their depression before and after being involved in the intervention. In only 3 of the studies were they consulted with and involved more in the design of the intervention. So 6 of those studies, they provided self-report data or they were interviewed across 5 of them. Sometimes they were provided self-report data and they were also interviewed. And in 2 of them, they were involved in the design by being involved in workshops or focus groups. And in 1 study, they were part of the feasibility study in the sense that they tested and provided data to the researchers about how well the study kind of fitted the purposes and ways they could improve it. So what are the general findings? We do need to be tentative with this because a lot of these findings are around really what the authors of these studies are saying that they found, rather than a summary of lots of findings across lots of papers. So of course, most of these are centered around a few papers rather than being centered around all 11, because some of those 11 were just looking at effectiveness and measured children's outcomes. So the findings really are across these studies that involving children improves the effectiveness. It maximizes the feasibility, so it makes it more likely that it will be uptaken. It's more tailored to children's needs. It ensures that the programme is more enjoyable for children and user-friendly, and it all incorporates perspectives from multiple and often contrasting perspectives. So when you look at the self-reporting, the outcome measures often differed from parents to children across some of the studies, and often what children were saying about what was important to them or of value to them from the intervention was different to what parents were saying, sometimes, not all of the time. Children tended to highlight slightly different things that they valued. So they valued the resources being graphically or visually appealing. They liked activities rather than more practical activities. So they talked about colouring and interactive features. So one of the interventions rewarded children with stickers, and they liked that kind of interactivity. Or some of the online apps enabled them to create their own kind of profile or their avatar online, and they liked this nature of interaction. So adaptability was really important to them, and personalisation of what they were doing. And what's really kind of lovely that comes out is kind of, I think, an added bonus of these type of interventions that children really value, because it carves out this one-to-one time for them with their parent, and they talk about it improving their closeness with that parent that they are doing the intervention with. So it has this kind of added impact that children really, really value. So just some really tentative recommendations from what we found so far. Involving children in the design, the implementation, evaluation is possible. As we've already alluded to in the presentations so far, as similar to parents, involving children needs careful planning, longer lead times. There needs to be time to build rapport and building relationships that kind of foster engagement. Also doing it in an iterative way rather than just consultating with children on a once-off, enabling children to comment on changes, because it's difficult sometimes for children to talk without seeing the changes that take place, and then they can input again. So the ones that worked really effectively, they had multiple times that they made changes, then talked to children again, made more changes. So children could visualize what the changes looked like and then comment on them. Interviewing doesn't seem to be the most effective approach with children. A couple of these papers talk about how children's responses were really brief, and the data you get from the interviews really contrasted with what you got from parents. Parents' data was much more rich and in-depth, whereas children's responses were really brief. So really, in order to get meaningful consultation from children or involve them in a meaningful way, we need to think about ways of doing participatory activities that enable them to give us more effective and rich data. So similar to what they're saying about the interventions, is there needs to be something that's visual, tactile, and activity based for them to give their opinions and their perspectives rather than just being interviewed. This we're continuing to do some work relating to this, and because there were very few papers, we want to speak to some children. So we're going to do some participatory workshops with children to find out what they think we should do to involve them in these types of intervention. Some of those workshops will be conducted with children that are experienced in PPI, so children that are involved in existing projects where they're being regularly consulted with, or they're involved as peer researchers on projects. And also we want to try look at into speaking to some of the children that parents have been involved in the participatory PPI work in the projects that we've been doing. Okay.
Many thanks, Rebecca. Really interesting and I think important findings there, and very helpful recommendations. And it's just been a real bonus that we've been able to do this piece of work alongside the primary studies at the sites. I'm sort of hopeful that this will hopefully influence other implementation studies and research more generally that might be done in this area. So now we are, as we come to the end of today's event, we have an opportunity for some reflections from our speakers today. Just before sort of handing over to them, just for me personally, something I'm going to be taking away from this is just sort of a further realization, if it was needed, that sort of implementation studies are so important alongside the randomized controlled trials that we do to test the effectiveness of studies. There's a whole other side of things in terms of how things operate in the real world or in the wild, I think, as Catherine said. Hearing about the experiences of two different teams and thinking about the commonalities and the differences in what came up, I think it really gives us a lot to think about that we can take away and apply when we implement interventions, or specifically PLCBT, but other interventions in our own settings and contexts. So I just want to start, I think, by handing over to Kathy. If you want to sort of come back on any points or reflections. I know there's been a very active Q&A, and I know you've been very active, Kathy, in responding to kind of all the questions, and I was sort of keeping one eye on that, and there were some really excellent questions from the audience, so thanks to everyone who's contributed to that. So over to you, Kathy.
Yeah, thanks very much, Daniel. And I mean, first thing, just huge thanks to everyone who's spoken. It's been really wonderful to listen to all the work that's come out of this project, and obviously fantastic presentations from Tim and Catherine and their teams, but also I think we've obviously all got to highlight Rachel and the parents for their insights, which are so powerful and moving. So first of all, just really wanted to say huge thanks for all of that. I think across all the presentations, it's really heartwarming, I suppose, to hear that, you know, when Catherine said that clinicians really have reflected on how this sort of approach can be helpful by increasing parents' knowledge and confidence, because that's really, from our point of view, what we've been trying to do all the way along. So wonderful to hear that even when it's out there in the wild, those sorts of messages are getting across. I mean, we're very aware of where Catherine highlighted some particular challenges that came up from clinicians. There's certainly things that we've been very aware of, and very much hope that our move towards Aussie and the online approach, I mean, we don't expect that to be necessarily right for everyone, but we hope it can address some of the challenges that Catherine raised. So it involves less time, it's much more flexible for families, it's been written at a much lower level of language literacy demands. It comes with an audio accompaniment that includes families from a broad range of ethnic backgrounds. It comes with a game app for children, so very much reflect, which came out of the co-design, so very much reflecting the work that Rebecca's just been speaking about, and the importance of having, you know, engaging, fun ways of children to be encouraged to get on board and work with their parents on these sorts of things. So very much hope, I mean, we're very aware of those challenges in terms of where this approach sort of started, and very much hope that that move to making the most of digital to increase flexibility and access will really help with some of those things. So it was really nice to hear both from Catherine and Tim that there seems to be positive feedback in terms of Aussie potentially being more accessible, fitting around the lives of many families. So we're really encouraged about that, and hopefully ultimately we'll be able to, you know, present choice for families to do what works for them. I think, and obviously wonderful to hear about, so from Catherine, we heard about what sort of happens when things are sort of let loose in practice. And I think that's probably what happens in most of the places around the country. And then great to hear that in parallel with the new model that Tim and colleagues described, to sort of, that has obviously potential to further increase access by working with a broader range of professionals. And I guess, you know, that's wonderful to hear as a model, and really suggests there's great opportunities to really increase access much further. But I think also really highlights the need for very specific training and support for both providers and for parents to help with this implementation. And I think, you know, those are things that are not normally available in routine practice, both for practitioners and for families. And so I'm really looking forward to working with the teams going forwards to help think about how we can make sure that we can create those sorts of resources to make sure that both practitioners and families have the support they need as these things are rolled out. So thanks very much.
Great, thanks very much, Kathy. So now just to hand it over to our colleagues who were working in the East of England and Northwest Coast. Catherine, do you want to come back with any reflections?
I think mainly just you know, to reiterate what Kathy's just been saying about the, you know, there isn't one size fits all, and, you know, for every disadvantage that somebody will raise, that somebody else, that's a positive. So it's, you know, I think the thing that comes across to me very strongly is having this kind of broad suite of resources and approaches that mean that, you know, that as many people as possible can engage, you know, in a way that suits them. So I think that's something that, you know, I will take away from listening to people talking today.
Great. Tim?
Well, you know me, Daniel, I've got a number of reflections, but I'll try and keep it short. I suppose the biggest reflection for me as I've been listening to this is how wonderful it is to think that, you know, often research and evidence that's generated out of research and all the work that Kathy and her team have done can often not be implemented routinely into practice. You know, I've worked on numerous research trials and projects, as have you, Daniel, and others on the call, I'm sure, where actually we don't end up, you know, disseminating, let alone implementing these new evidence-based approaches into practice. And it breaks my heart. It's so sad because of the amount of public funding, the amount of participation work that goes into it. So this is a really great example how we can all rally around together, you know, from funders of research to the actual developers of the interventions and innovations, the research teams, the commissioners, you know, the pastoral workers, us clinicians on the ground. You know, those bridging roles and these types of projects absolutely have to happen much more regularly and routinely. I hate to think how many interventions, you know, that could benefit children and young people are still sitting kind of gathering dust and not being implemented into practice. So this is a really great example of how it can be done. We can all rally around together to implement these things into practice. And you know, it's relational in aspect. So you know, we need to create those relationships, we need to nurture those relationships, and we need to actively and assertively bring those roles and organizations together. So I think that's kind of the main message that I would take away from today's webinar. I don't know whether Natalie wants to reflect on anything from a school's perspective with reference to our WOW project as well, Daniel. Thanks.
Yeah, great. Go ahead, Natalie.
Thank you. I'll just, I'm like Tim, and I could reflect for hours, because for us, this has been sort of 4 years that we've been working together on this. And for me, it's just incredible. I think one of the most important things that we've talked about quite a bit is the relationships that have been built across organisations. So bringing health alongside education, which is something that's been really missing for a long time. And that's been really, really important to me. And also the relationships that we have with our families and that knowledge that we have. I think I feel very privileged to see the longer term impact that this has for children, which is something that I think clinicians don't always have the opportunity to see. And for me, that's just amazing. We follow these children and these families on their journeys, and it's just incredible. I think that sort of empowering parents, that we often kind of sit alongside them when they're feeling really helpless. They don't know what to do and where to turn, and we're in this sort of holding period. So it's really empowered us to empower them to kind of make those changes, which has been yeah, incredible. And if it's okay, I'd just like to share a quote from our executive head teacher, because she, I think we've talked quite a lot in terms of the development and the sustainability about having that buy-in from senior leaders. And for us as a federation, it goes back to our governors. I have to report back to our governors regularly, and the WOW project is a key part of my report. So having that buy-in, and something that she said is, by making the investment in this programme, it reduces significantly the need to refer children to external agencies with huge waiting lists. But most importantly, we see the positive impact it has on our children in our schools on a daily basis. So children with mild to moderate anxiety are able to come into school feeling safe and confident. Therefore, attendance and punctuality improves, the resistance to enter school diminishes. So children can then more successfully participate in the full life of our school, and their engagement with education increases. That's it from me.
So how hard is that to follow, Natalie? And you picked up the point that I was about to raise. I think you're absolutely right. Relationships are absolutely key. That's what I take away in implementation. Relationships, not just with wider system stakeholders between health and education, but also at schools, our education settings, and most important, our parents and children and young people. And that's just been at the forefront for the last couple of hours. So I just want to reiterate what you said, Natalie, much more articulately than I ever could. I think the other two quick points for me, as I previously spent years commissioning, is around sustainability. Great to see East of England looking at that buy-in from ICB to sustain some of this work going forward. It's really important to involve your commissioners very early. One of the outputs of this piece of work has been, this MHIN has been, to create some tips to enable you to do that in terms of research, how you can engage with your commissioners. So please do look out for that. And most importantly, I think it's absolutely worth highlighting how powerful the voice of our parents that have been involved in this intervention has been critical for any success. So thank you for that. And on that note, the last 5 minutes, for those of you that have stayed on, you get the best bit, because you get to hear how we're going to continue some of this work and how you can be involved going forward. Thank you to all of those that have been involved in the reflections there. I'm sure we could continue more, but I really appreciate your input off the cuff, so thank you. Next slide, please, Flavia. So as Daniel said, this mental health implementation network has been funded through NIHR. We've just heard that we have got an extension of another year to continue this work, which is really exciting. We're still working out the mechanisms for that, but there is a feedback form that you can complete. And if you're interested in being involved in this going forward, or getting hold of some of the resources that have been talked about today and that will be developed over the next year, do please fill in the feedback form, because you can definitely access those if you're looking at implementing in your area. We, would like to thank Kathy. Kathy, you've been a dream to work with. So we continue to work with you going forward over the next year, and Coa Health, your commercial partner. And great that the 2 sites that we've heard from today, East of England and North West Coast, will continue to be involved and be able to share some of their learning and resources with those of you on the call that want to take this further in your areas. And those kind of learning and resources that will be available will be toolkits, videos, blogs, some communities of practice that will be able to hold in other areas and share the learning, some training and some mentoring. So really brilliant that we've been able to secure this funding to take us for another year to be able to make best use of all those all that learning. And finally, so I've talked about the extension. There's the website. If Sundus could someone could kindly put that in the chat so you can see it or access it for more information on what we've been doing, as we are one of 3 projects that you can have more information on that website. I've already said, please do complete the feedback form to register interest in being involved going forward. We will share the resources and learning, as we've said. And we will share slides from today and the videos and some of the questions that we've seen in the chat. And finally, I just want to take this opportunity to thank everyone that's been involved in this last 18 months, every single stakeholder, every single member of this project group, every single member of the reference group that's kind of worked with us to take this forward and support and guide us and provide critical input. Our 2 ARCs that have done a fabulous, you've heard today, they've done a fabulous job. Most importantly, our parents that have been involved and to help kind of challenge us and guide us through this process. And the MHIN core team who've put today together and helped kind of pull the resources together for our sites and for us as a national network. And on that note, I think I will say thank you very much to you for attending. A recording of this will be available on our website, so if you do want to access the event and the detail that you've heard today, please do log on to the website that we've given you the details of. But on behalf of Danny, myself and everyone that's talked today, thank you very much for your time.